Welcome, everyone, and thank you for joining us for this evening's presentation. As you know, ECHO is hosted by the Gastro Foundation in association with Project ECHO from the University of New Mexico. ECHO Fellows is run every Monday at 6. And so during the presentation, if you have any questions, you can post them in the chat, and we'll get to them at the end of the presentation, or you can also just unmute at the end and then just ask the question. So I'd like to encourage all the fellows to, ask questions. So let this be like a discussion so that we can all learn something from it. So this evening, the talk will be given by Dr. Joseph Adebiyi, who's a fellow at Charlotte Maxeke. He is a second-year fellow. He's going to be talking about different types of colitis: microscopic colitis, diversion colitis, and the other one, Joseph?
Ischemic colitis.
Colitis, yes, of course. All right, so I'm gonna hand over to you then, Joseph.
Thank you, Dr. Siabi. Can I just confirm if you can hear me?
Yes.
Okay, so welcome everyone. This evening we are going to be zeroing on a couple of colitiditis, basically microscopic colitis, ischemic colitis, and diversion colitis. These are large, huge topics, but we will try to go through all of them in the hour that we have. So this will be the outline that I would be going through for the 3 topics that we'll be talking about. And we will start with microscopic colitis. So it is a commonly recognized inflammatory disease of the colon, and it is majorly characterized by non-bloody, watery chronic diarrhea. It was actually first described in 1980. It's basically a disease or a form of colitis that would usually have normal macroscopic features on endoscopy, but we then have typical inflammatory features when you do the biopsy. It essentially has two histologic, well-differentiated entities, which are marked or differentiated by the presence or lack thereof of the thickening of the subepithelial collagen table. And these are essentially lymphocytic and collagenous colitis. There is a third entity which has also been described as an incomplete microscopic colitis. We'll see later on how this differs from the other 2 types of microscopic colitis that have been described. It is unclear if these entities are a continuum or if they are distinct diseases on their own. Certainly, we've seen several cases of patients who in whom one diagnosis was initially made and then was later on changed to the other form. So you had a patient who would have initially been diagnosed as having lymphocytic colitis and then later on described to have microscopic collagenous colitis. And then you have also seen cases of patients having, simultaneous involvement of the 2 histologic subtypes. It is indeed a fairly common cause of chronic diarrhea, and certainly the numbers have been increasing over the past few years, and this correlates nicely with an increasing age and increasing life expectancy. With advent of technology and improvement in healthcare, we're seeing people growing older. And because it's basically a disease of the old age, elderly people, we've seen that the numbers have actually increased. And most series are actually would suggest that the incidence would be around about 11.4 cases per 100,000 person years. And this is basically similar to what you'll find in patients with Crohn's disease and ulcerative colitis. So indeed, it is not an uncommon disease. And when you look at pooled overall numbers from 5 Western countries, including Spain, Sweden, and even North America, and these have shown that the numbers have been increasing. And if you look at a typical tertiary center, where if you look at all the patients who they see at a typical tertiary center who would present with chronic watery diarrhea, we have seen that about 7 to 20% of those patients would have microscopic colitis. There is a significant female to male preponderance, and the reason for this is unknown. And then, like I said earlier, there is a strong predilection for the elderly patients with a median age of about 65 years. Just under 25% of patients would present at an age of less than 45. And most studies have shown that the collagenous subtype is more prevalent or more common than you'll find the lymphocytic subtype. Looking at this data, this graph from the Homestead County in Minnesota, actually it was presented by the Mayo Clinic. And this graph actually looked at the age and the gender specific incidence rates at the Homestead County in Minnesota. And this was published in the American College of Gastroenterology in 2016. You can see clearly that before the age of 40 to 50, the numbers are quite low, less than 10. But when you progress to the older age, between 60 and 70 years of age, you can see that actually there's a significant increase in the numbers when you look at the older patients. And again, if you compare the two genders, looking at the female and the male genders, you can see that this is a clear, significant higher numbers of patients who are female presenting with microscopic colitis. Again, looking at this presentation, again from the same journal in 2016, and this actually looks at the presentation, the incidence of microscopic colitis over time. And you can see, just like we said earlier, that the numbers have actually been increasing in the past couple of 2-3 decades, and in line with the increase in the number of patients who are getting older. You can see before 1990, most of the cases actually not a lot. But when you look at from 1990 upwards up to 2011, you can see that there's significant increase in the number of patients who are presenting with microscopic colitis. And another, a lot of other strong articles have also looked at the age incidence and the presentations and the numbers of patients who present with microscopic colitis. And certainly a study which was presented in 2015 in American Journal of Gastroenterology by Tong et al. Looking at doing a systematic review of a number of cases, and they looked at 25 studies, looking at just under 2,000 citations. And they did show that the collagenous colitis was seen about 4.85 per 100,000 person years, and compared to 4.15 for lymphocytic colitis. And this is in keeping with collagenous colitis having a slight more preponderance. And again, looking at the female to male incidence, you can see that the females have a higher preponderance. Most of the patients have a median age at diagnosis of collagenous colitis, usually around about 65 years of age. And this table actually compares a number of studies looking at the age of diagnosis and the gender. And most of actually all the studies actually, correlate well with each other, and most of the patients would usually present around about 66 in the 60th decade of life. And we can also see that most of the patients were female if you look at all the studies that were done. There's not much data to look at in Africa. Not much in terms of studies for microscopic colitis has been done, and not much has been presented. Just a couple of isolated cases of lymphocytic colitis were reported in Nigeria. And just one study that I saw, which was done in Tigerberg Hospital in 2011, did demonstrate some cases of some cases of mixed microscopic colitis when they had done further histopathological evaluation, meaning they essentially find that actually this patient might have had microscopic colitis. So what would be the risk factors or etiology for microscopic colitis? Most of it is largely unknown, but a lot of the presentations and a lot of the papers actually would suggest that there is a complex interrelationship between genetic and environmental triggers and factors, which have correlated nicely for microscopic colitis in terms of the etiology and risk factors. And talking about the genetic, there is a strong family clusters. You find that they sometimes run in families, and then there's been cases that have been reported of microscopic colitis occurring in twins. Looking at the HLA DQ2, DQ1, DQ3, DR3, DQ2, these are being found in patients with microscopic colitis, again, in keeping with a strong genetic implication for patients of microscopic colitis. And the procollagen and metaproteinase 9 gene variations have also been reported in patients who have microscopic colitis. And the presence of these gene variations actually suggests that some of these patients, these gene variations show that, or they describe patients who then go on to have microscopic colitis with the presence of these gene variations actually predisposes these patients to having accumulation of collagen deposits in the subepithelial area, and then which then is in keeping with patients who would then have the collagenous subtype of microscopic colitis. There are also several associations and risk factors which again have been described for microscopic colitis. Looking at this table, which had picked up from the Mayo Clinic publication. Again, looking at demographic characteristics, most of the patients are middle-aged patients, and they are women. So being a woman and being a middle-aged patient is actually a risk factor for patients developing microscopic colitis. And then there is also strong association with the use of certain medications, certainly proton pump inhibitors, and especially NSAIDs and AC inhibitors, and as well as statins have been described as predisposing patients to having microscopic colitis. And a lot of those patients who have microscopic colitis have been known to have to use these medications. It is a bit of a challenge because these medications actually are the same medications that have been implicated in the development of chronic diarrhea on their own. For example, patients using NSAIDs as chronically have been known to have pill-induced colitis. Whether this is as a result of the microscopic colitis that they develop whilst using NSAIDs is a causality implication or relationship is left unknown. But what has been known, or what has been found, is that a lot of those patients who have microscopic colitis have been known to use PPIs and NSAIDs on a long-term basis. There's also a close relationship with patients with autoimmune diseases, especially rheumatoid arthritis and the thyroid diseases, as well as diabetes and certainly celiac spore. Smoking has also been associated with the development of microscopic colitis. Essentially. So this is a long list of drugs basically that have been shown to trigger microscopic colitis, but the high likelihood of these drugs are in the region of drugs, patients taking alcohols, NSAIDs, like I said, and your PPIs. The other drugs are less likely to cause or to trigger microscopic colitis. Again, still talking about associations, and like I said, it's a strong association with celiac disease, especially, and the HLA-DR3 DQ2 haplotype, which which basically predisposes patients to celiac disease, have been found have been found in patients with microscopic colitis. And then certain inflammatory constituents like your T helper, type 2, type 1 mucosal cytokines, and your interferon gamma, interleukin 15, your tumor necrotic factor, your nitric oxide synthase, which are basically found have been implicated in the development of inflammation in patients with celiac disease, have also been found. These entities have also been found in patients with microscopic colitis, which again lends credence to a strong association between microscopic colitis and celiac disease. And in certain studies, about 2 to 9% of patients who have microscopic colitis will then have certain features of celiac disease in their small bowel, things like having flat villi or having cryptataplasia would then be found in patients who were ab initio diagnosed microscopic colitis. When you then look in their bowel, small bowel, then you then find features of celiac disease. All that combined with having those inflammatory entities again suggests that there's a strong relationship. And then you then find patients who have been diagnosed with celiac disease, and then when you look into their colon, you find colitis. And that has made people to start talking about the entity called celiac colopathy. And then there is also rare cases of concurrent relationship or concurrent reporting of microscopic colitis in patients who had inflammatory bowel disease, especially ulcerative colitis. Or you find patients who have ulcerative colitis and then you then find them having features of microscopic colitis. And then certain individuals who have microscopic colitis have then been shown to have lymphocytic or collagenous gastritis in their stomach. So smoking has also been shown to play a strong role in the development of microscopic colitis, and then also it also influences the clinical outcome. In a case study, a case control study involving 340 patients with microscopic colitis, a lot of these patients actually had history of smoking, whether it was in the past or it was they're currently smoking. And it was shown that there's a strong association between they developing microscopic colitis with an odds ratio of 2.1. And then on the average, most of the patients who smoke would then develop microscopic colitis about 10 years earlier than patients who didn't smoke. So, and then with smoking and microscopic colitis, it tends to have persistent disease, and they also have a lower probability of achieving remission on treatment. So what is the pathophysiogenesis of microscopic colitis? Again, most of the mechanisms are not known, but there are some potential pathophysiologic pathways that have been proposed. And like I said, it's a strong genetic and environmental complex interrelationship. And so you find a patient who has a genetic susceptibility, has the HLA, DR3, like I said earlier, or they have those inflammatory gene variations that have been described earlier. So you have those patients who have the genetic susceptibility, and then when they're exposed to certain environmental triggers like the drugs, they have bile acids, or they have certain infections, or they even have some food antigens. So all this interrelate and interact, and then leading to the release of histamines and prostaglandins and even nitric oxide, essentially leading to epithelial damage. And then this would then stimulate some immune activation with increased secretions, and then essentially stimulating pericryptal fibroblasts, which then leads to increased collagen synthesis and with reduced degradation of collagen and reduced fibrinolysis, and then essentially leading to lymphocytic colitis and or collagenous colitis. Again, this is a nice diagram to look at what happens at intracellular level around about the cell membrane, with the complex introduction of luminal triggers and luminal factors leading to altered antigen presentation with activation of certain inflammatory markers and inflammatory entities. Then all this lead to increased interstitial permeability with epithelial damage and increased increased production of inflammatory markers, and then this would then lead to increased collagen deposition, and it would then lead to the development of microscopic colitis. Again, this is essentially looking more at the area of the subepithelial levels, where you have increased expression of fibroblasts, which then lead to thickening production of inflammatory mediation and subepithelial fibroblast stimulation, and of course collagen deposition. So in summary, you have complex interactions of these genetic and environmental factors, and then leading basically to abnormal fluid and electrolyte secretion and absorption. So you have a problem with sodium chloride and water, both absorption and secretion, and then leading to net secretion of these substances, and then this lead to diarrhea, and then bile acid malabsorption, and then this with abnormal collagen synthesis and degradation, but tending towards more of collagen synthesis, and then interaction with infections. Certain patients with certain infections have also been shown to be involved in the pathogenesis of microscopic colitis, and then with drugs as well. So how do those patients present? So typically you find a middle-aged or an elderly female patient who would present with chronic watery, non-bloody diarrhea. And this usually will have insidious onset in most cases, and then progressing to become chronic, intermittent, or even chronic persistent. Usually the diarrhea or the loose stools would be around about 4 to 9 per day, but cases of up to 15 bowel movements per day have been described. Typically, most of these diarrheas are usually mild and self-limited, but they may progress to severe or refractory chronic watery diarrhea. In 70% of cases, fecal urgency would be the complaint. And then nocturnal episodes would be around about 50% of presentations. Certainly about 50% of the patients who have abdominal pain. Fecal incontinence has also been described, and then there is associated weight loss. And the reasons for the weight loss would be because these patients are constantly going to the bathroom to move their bowel, so they're scared to eat, and sometimes and because because of the weight, because of the constant watery diarrhea, as well as the inability or the refusal or the the food aversion. So you then find that these patients would then lose weight. Steatorrhea has also been reported, again, confounding the involvement or the association with celiac disease. So the watery diarrhea, again, it's been described in about 84 to 100% of patients in about 22 studies. And in a study, in a Swedish study, which was presented in 2004, involving almost 200 patients, showed that weight loss was reported in more than half of the patients. In terms of diagnosis, you want to, first of all, exclude close differential for causes of chronic diarrhea. So you want to exclude chronic infections. You want to exclude things like your celiac disease, your inflammatory bowel disease, and you want to exclude your irritable bowel disease. And you do this by a combination of careful history, physical examination, and laboratory studies, and endoscopic evaluation with histology. So your history basically should include recent antibiotic, basically drugs, and you want to rule out other autoimmune diseases, and you want to find out if there's any relationship between the cases and IBD. And then physical examinations usually are non-specific, but you may find features of extraintestinal manifestations of inflammatory bowel disease if there's an association. In terms of laboratory investigations, you want to take your stool cultures, specimens for microscopy and ova of parasites. There has been reported cases of inflammatory markers such as myeloperoxidase and tryptase, which have been detected in the stools of patients who have collagenous colitis. And then all other non-specific laboratory investigations that you need to do, your full blood count and your albumin to look for anemia and to look for, other things that may be related to celiac disease. Of course, you want to do your celiac serology. In terms of fecal calprotectin, it's been shown to not be specifically useful to exclude or to include, to exclude microscopic colitis, or certainly even to monitor it. A study which was done by Wild et al., which was published in 2011, demonstrated that fecal calprotectin was basically increased in some patients, but not all the patients who actually had active collagenous colitis. And then there was significant overlap between patients who had both active or quiescent disease, or even patients who had normal control. So it was normal control. So it was quite difficult to be able to use fecal calprotectin in the setting of microscopic colitis. So the next thing you want to do is to scope this patient. So, but why would you want to scope those patients? But you first of all have to decide what are the chances that if you scope this patient, you might end up finding features of microscopic colitis. So if your patient is above 50 years old, is female, there's a history of use of PPIs, of NSAIDs, the patient has been losing weight, and there's maybe absence of abdominal pain, and it has typical watery diarrhea, then you may be thinking, are we dealing with microscopic colitis here? And then if you combine all these factors together, there is actually a 90 to 94% chance that you might be dealing with microscopic colitis. Using these tools may actually help avoiding doing unnecessary colonoscopy for patients. But when would you then end up doing colonoscopy for this patient? So if you have patients who essentially have chronic watery diarrhea with alarm symptoms, or you want to scope them basically because there's age-appropriate colon CA screening, or you're trying to differentiate between those patients and those who have IBD, or you're trying to rule out celiac disease, or if you have patients who have persistent symptoms. So what's usually the endoscopic findings in those patients? Usually normal, most times it's usually normal mucosa that you would find. But there has been increasing recognition of patients who then have you know, macroscopic features on endoscopy, but these features are usually non-specific. When you look at about 80, there was a study that looked at 80 informative articles, looking at about 1,500 patients. Endoscopic findings were identified in more than half of the patients who had in collagenous colitis, and more than half also in patients who had lymphocytic colitis. So the typical macroscopic findings usually, like I said, are non-specific, but most of the time they're usually linear ulcerations. You may end up finding pseudomembranes, which may then confuse with Clostridium difficile. Then you may also find irregular vascular patterns with mucosal lacerations. You may find erythema, edema, nodularity, and surface textural alterations. Sometimes, because of the thickness of the subepithelial collagen plate, you may then find that these patients may then have perforations, and this may have been described as fractured colon. So where should biopsies be taken in patients who are suspected to have microscopic colitis? So it's advised that this biopsy should be taken from both left and right sides of the colon. And studies have shown that biopsies that are taken from left and right colon have up to about 95 to 98% chance of having histologic changes of microscopic colitis if they indeed have microscopic colitis. And then studies which don't have strict biopsy protocol have actually reported lower number of diagnostic biopsies from both sides of the colon. Sometimes, most times, rectosigmoid or even your flexible sigmoidotomy has been shown to reveal microscopic colitic changes in about 90% of cases. So, but biopsies taken from the rectum are essentially not sufficient. It is also recommended to take samples separately, to label the samples separately. And the reason is because there is higher laminal propria on the right side. So if you don't label them properly, it may then confuse the pathologists, because they may then describe having higher laminar propria with thicker collagenous bands, which have been reported in the sigmoid and even in the rectum. So they may then confuse these changes as microscopic colitis. But when you label and you label your samples properly, and then you say this is from the left, this is from the right, and then they may be able to compare those changes. That's one. Two, although people have said that this may not be necessary because of the expenses that have been involved. I mean, certain pathologists will charge, or certain laboratories will charge per sample that is taken. So, but it's essentially important that the general consensus among pathologists is to say, take samples separately from both sides of the colon and label them separately. So the histological changes that you'd find in terms of criteria for collagenous colitis are taking subepithelial collagenous bands, which would be more than 10 millimeters. That combined with increased inflammatory infiltrate in the laminar propria would then help you to diagnose collagenous colitis. And the collagenous band is usually irregular with deeper edge, and then may contain some entrapped capillaries, some red cells and inflammatory cells. And then you may also find focal damage of the surface epithelium with detachment from the basement and flattening and mucin depletion. And then when you combine all this with increased numbers of intraepithelial lymphocytes, then you then diagnose the patients with collagenous colitis. For patients with lymphocytic colitis, you are looking for increased numbers of intraepithelial lymphocytes per 100 cells, epithelial cells, usually more than 20. But when you look at the collagenous band, it's thick but less than 10, and then this differentiates it from collagenous colitis. The third entity, the incomplete microscopic colitis, doesn't fulfill the criteria for either lymphocytic or collagenous colitis. So this is typically what you'll find. You find thickened subepithelial areas, which shows increased collagenous deposits with inflammatory. You can see the large numbers of inflammatory cells, so specifically lymphocytes, which have been demonstrated in this slide. And then you also want to differentiate the patients who have microscopic colitis from patients who have functional diarrhea, as well as patients who have IBS. So you find that, looking at the gender, you find that most of the patients in microscopic colitis are females, less so in patients who have functional diarrhea, and again, less so with patients who have autoimmune diseases. And then if you compare microscopic, looking at the number of the number of diarrheas in the three special conditions, you find that there is more diarrhea in patients who have functional diarrhea as compared to microscopic colitis. And then the abdominal pain is also more involved in patients who have IBS. Again, looking at the differential diagnosis for microscopic colitis, you find that patients who have infective colitis, usually watery, and then you then detect toxins when you examine the stools. And the patients who have celiac disease, there's more of steatorrhea, and then you find positive serological tests. And patients with inflammatory bowel disease usually would have bloody diarrhea. And then, but compared to patients who have microscopic colitis, if they have Crohn's disease, you may end up finding granulomatous changes on biopsy. So how do you manage these patients? So treatment generally is based on the severity of the patient's symptoms. So the initial approach is to identify and you remove the trigger. So if the patient is taking drugs that may have been shown to trigger microscopic colitis, you want to remove that. If the patient smokes, you want to stop them from smoking. If they have or if they're taking medications or eating foods that are been known to trigger microscopic colitis or trigger the diarrhea, then you want to remove those triggers. But essentially for patients who have mild symptoms, antidiarrheals may be sufficient. Things like your loperamide may be sufficient. But for patients who have mild to moderate refractory diseases, then you may end up giving them bismuth subsalicylate, giving them about 9 tablets per day for 6 to 8 weeks may be used. In this study, which was published in 2015, basically an open label bismuth trial published in 2015, involving just about 64 patients, 52% of them having lymphocytic colitis. They were given 6 to 9 tablets of bismuth over 8 weeks. And there was complete response in about 48% of this patient. 20% of this patient didn't have any response at all. But there was, when you do adjustment based on the dose, you find that patients who were taking the 9 tablets per day had about 63% of them had remission, as opposed to 35% of patients who were given 6 to 8 tablets. So if you are giving patient bismuth subsalicylate, you actually want to give them 9 tablets per day. So then the use of budenoside is for patients who do not respond to antidiarrheals, or patients who have severe disease, severe active disease. And an active disease is patients who have more than 3 stools per day or more than 1 watery stools per day. So for oral budenoside, you want to give them 9 milligrams for 6 to 8 weeks. It's actually, it has fewer side effects. It has less it has extensive first pass metabolism, so it has less side effects. The only issues are that it's not readily available, and it can be expensive. So we end up having to use prednisone or steroids instead. In a meta-analysis involving 6 randomized clinical trials, actually showed significant or clear benefit of budesonide to induce clinical response. So 4 of those randomized clinical trials involved patients who had collagenous colitis and 2 in lymphocytic colitis. 9, so most of those patients were given 9 milligrams and they were kept over 6 to 8 weeks, and there was complete response in about 85% of those patients. The only issue again here is relapse. So once you stop these medications, about 80% of this patient will relapse after they've been stopped budesonide. So the treatment goal is clinical remission, and clinical remission is described as patients having less than 3 stools per day or no watery stools per day. And then there must be increased or improved quality of life. The validated gastrointestinal quality of life index was used to measure the quality of life at baseline, and at 6 weeks following treatment with patients who were given budesonide versus patients who were given placebo. There was complete quality of life assessment was done in about 29% trial participants, and they found that 67% of the patients in the budesonide group had improved quality of life, as opposed to 86% in the patients who were in the placebo group. So like I said, a relapse is quite common in these patients, and when they relapse, you may then continue with budesonide at maintenance, but at a lower dose, maybe between 3 milligrams to 6 milligrams, and you may even alternate over 12 months. And this has been shown to have similar efficacy. But patients who are older, who have longer duration of symptoms, who have higher stool frequency at presentation, they are at higher risk of relapsing. You may then consider other alternatives if you find that budesonide is expensive. It is said that you don't need to really do repeat colonoscopy to assess histological response. Now, for patients who don't respond to budesonide or who have persistent symptoms after budesonide, or they keep having relapses, and then you may then use your thiopurine, your methotrexate, and your biologic agents. So things like azathioprine has been shown to help in patients with microscopic colitis, according to several studies, including this one that involved 9 patients. So this will be essentially the summary of how you manage a patient with microscopic colitis. So you first want to discontinue all triggers and encourage patients to stop smoking. And then you may initially, depending on the severity of the disease, you may try loperamide or bismuth. And if the symptoms are persistent and the patient doesn't respond, then you may then progress to using steroids, basically budesonide. And if the patient doesn't respond, then you may then go on to immunotherapy with the use of immunomodulators and your TNFs. So that would be that for ischemic colitis. For microscopic colitis. For ischemic colitis, it's actually quite a common cause of ischemic injury, the most common actually of ischemic injury in the GI tract. It can either be occlusive or non-occlusive. It usually would occur in acute transient. It occurs when there's acute transient compromise in the blood flow, and in the blood flow which is below the requirement for metabolic needs of the colon. So essentially, this then leads to mucosal ulceration, inflammation, and sometimes even hemorrhage. The presentation and severity and disease behavior actually varies considerably. And sometimes some of these patients may then go beyond having acute ischemic colitis, and then they progress to the chronic form. more than half of patients who present with gastrointestinal ischemia will have a ischemic colitis. And it's been described in about 6.1 cases per 100,000 person years, which initially in the 70s, but the numbers have actually increased, again, in keeping with the presentation or the predilection for older people. And then when you do colonoscopies, it's been shown to be found in about 22%, 22 out of about 100,000 colonoscopic procedures. And in tertiary centers, it's about 1 in 2,000 hospital admissions. But the numbers have actually been underestimated and sometimes have been misdiagnosed because most of the cases are transient, and then most of the cases, or some of the cases, have been misdiagnosed as inflammatory bowel disease. And then more than 90% of the cases will occur in people who are above 60 years of age, because most of those patients are the ones who would have, risk factors for ischemic diseases, cardiovascular diseases, and all that. But the numbers in younger people have also been reported. So most of the the risk factors, so old age is a risk factor, as most 90% of patients with collagenous, ischemic colitis are usually in older people. And in younger patients, usually the risk factor would be vasculitis or even coagulation disorders, and especially the use of illicit drugs like cocaine. And then some iatrogenic causes, like the use of medications, have also been, certain medications have been implicated in causing or predisposing patients to developing ischemic colitis. Female gender is also a risk factor. So if you look at this age-related incidence over time, you can see that most of the patients are older patients and females, and the numbers have actually increased in the last couple of years. Other etiological risk factors would be patients who have thrombosis, all form of thrombosis, mesenteric artery thrombosis. If you have any hypoperfusion states, you have got congestive heart failure, or transient hypotension in the perioperative areas, patients who are shocked, or even mechanical colonic obstruction. Patients who have tumors, adhesions, even vulvi have been, diverticulitis have been implicated in the development of ischemic colitis. And there's a lot of medications, especially antibiotics and chemotherapy drugs, and even vasopressors have been implicated in the development of microscopic colitis. And then colon ischemia or ischemic colitis have also been shown to follow aortic surgeries like aortic reconstruction, and also aortic aneurysm. And also it may also complicate coronary artery bypass surgery. And then sometimes ischemic colitis may just spontaneously appear in healthy individuals. But the etiology or the reason for this it's actually unclear, and this has been described as idiopathic or spontaneous ischemic colitis. So having a quick look at the anatomic consideration. So the major blood supplies to the colon is from the superior mesenteric artery as well as the inferior mesenteric artery. And this artery basically arises from the aorta around about the L1, L2 intercostal space, and for L1, L2 space. And then, it supplies basically the distal part of the small intestine and the cecum, and then supplies ascending the colon up onto the proximal third of the transverse colon. It basically essentially has 4 branches which are distributed around the colon. And then the other major artery that supplies the colon is the inferior mesenteric artery. And this arises from the aorta, just about 3 centimeters proximal to the bifurcation of the aorta around about the L3. It also has several branches which are distributed around the colon, but it essentially supplies the rest of the distal part of the colon up to the rectum. So ischemic damage rarely affect the rectum because it does have a lot of collateral supply, basically from the inferior mesenteric artery and some from the iliac arteries. But the key thing here is that there's considerably overlap in the supply of the colon, involving the superior and the inferior mesenteric arteries, such that there are areas of anastomosis, and these areas of anastomosis portends weak points where you can then have watershed. These are watershed areas which are then prone to ischemia during periods of hypertension. And these weak points are around about the splenic flexure and the rectosigmoid junction. So this is essentially what I've been describing earlier on. You have the major arteries coming from here, from the aorta, the abdominal aorta, and in these areas are the weak points where which are more prone to developing ischemia during shocked or hypertensive state. There's a significant differences between mesenteric ischemia and ischemic colitis, because these two entities are sometimes confused. But just to note that mesenteric ischemia usually would affect the small bowel, and most of the causes are usually thromboembolic causes, as opposed to ischemic colitis, which is more likely to be caused by hypoperfusion. And the diagnosis majorly can be picked up from imaging and colonoscopy, whereas your mesenteric ischemia, you most times would need CT angio to diagnose it. And then comparing the left and right sides of the colon, most of the time, because the left side is the right side usually has smaller vessels, the vasa recta, so then it may then be prone to vasospasm and then may increase the susceptibility to ischemic colitis. So just looking at basically a summary of the pathophysiogenesis, we can find that essentially, all these risk factors that we've talked about: surgical repair, atherosclerotic narrowing with coronary artery disease, peripheral vascular disease, and then including things like your atrial fibrillation or even trauma, and then periods of hypertension, the non-occlusive hypertension, all these combined states with thrombosis and all that, we end up leading to inadequate blood supply to meet the cellular metabolic demands of the colon. And then this would then lead to ischemic colitis. So what usually will happen with initially this period of ischemic period, and then there is also the reperfusion periods where there is a rapid influx of oxygen, and then this may then lead to release of free radicals. These free radicals combined with the initial loss of oxygen may actually predispose to causing more tissue damage and more cell death. And then this may then lead to gangrene, and then with mucosal ulceration and colonic inflammation. And then with mucosal inflammation and mucosal ulceration, you may then have hemorrhage. With hemorrhage, the patient may be shocked and may have bloody stools, and then may have hypovolemic shock. And then with colonic inflammation, a couple of things may arise from colonic inflammation. You may have systemic inflammatory response syndrome. There may be nausea and vomiting with abdominal pain. You may have perforation with peritonitis and leukocytosis. All this will then lead to further systemic compromise of the patient. Ischemic colitis can be classified according to several classifications. You may have gangrenous or non-gangrenous. It may be classified as the non-gangrenous ischemic colitis can be transient or chronic. You may also have the classification by Bright and Bowley. And but the usual classification usually would then have a sort of a spectrum where you have the initial reversible colopathy and transient colitis, which usually will occur in most of the cases, but then it may then progress to chronic recurring colitis, which may be complicated by strictures and gangrene, or even fulminant universal colitis with perforation and systemic inflammatory disease. There may also be classification based on the depth of mucosal involvement. There's type 1C, which describes inflammation, which is just limited to the mucosa. There may be type 2, which may be involvement of the muscularis layer. And then once there's transmural inflammation, then you describe that as type 3. There's also clinical progression. So the initial phase is usually the hyperactive phase, just immediately after hypoperfusion, and then this may then they may then become associated with occlusion, with severe pain, and conservative measures would just be needed for this. Then you may also have the paralytic phase when the pain then diminishes, but then there's diffuse involvement of the colon, and if this is not quickly corrected, the patient may then progress to the shocked phase with electrolyte imbalances, dehydration, and this may require surgery. So the patients usually will present, most times patients may not actually be aware that they are going through colonic ischemia, but when they do present, about 87% of the patients would have abdominal pain, usually sudden acute onset abdominal pain, which may vary in severity. It may be mild, it may be actually very severe abdominal pain. 84% of the patient will have rectal bleeding, 56% will have diarrhea. Usually examination is usually non-specific, but usually the abdomen is soft, but you may then find tender abdomen. And then if the abdomen is peritonitic, you may have features of peritonitis. And then if depending again on the presentation, if the patient is shocked, or they may then progress to systemic inflammatory response, you may have systemic features with cardiovascular or systemic collapse. PR bleeding again is more common on the left side as opposed to the right side, but the right side usually presents with pain, mostly with pain. So when you investigate the patient, usually you take proper history, but inflammatory markers may suggest, may be raised in this patient with raised CRP and neutrophil count. You also need to do your CRP, you check your renal function, because sometimes with systemic involvement, you may then have acute kidney injury. You want to check your hemoglobin and your clotting profile. You also want to check your serum lactates, which helps you to determine the severity of the systemic involvement, as well as to help you to determine recovery and monitor the patient. And then in terms of imaging, the image of choice is your CT, is your contrasted CT. Usually you want to use your water-based contrast, but the significant features will be segmental region of abnormality with symmetrical or lobulated thickening of the bowel wall. You may find irregular narrowed lumen with submucosal edema, which may then show as low density ring bordering lumen, the so-called target sign. You may also find irregular narrowing of the bowel lumen. You may find thumbprinting, which you can find on CT scan or even on abdominal X-ray. You may also find intraluminal or portal venous gas with some mesenteric edema. You may then also find mesenteric artery occlusion, which may be demonstrated on CT scan. Abdominal X-ray is rarely used, but if you use it, you may find features of thumbprinting, which represent mucosal edema, but then you may also find dilated bowel from ileus, or you may find features of perforation with free intraperitoneal gas. So this is how a typical thumbprinting will look like. Again, that's how it will look. Barium enema is seldom used, but if you use it, make sure you use the water-based contrast, and it usually will show some non-specific narrowing over a segment of the bowel. Nuclear imaging, again, is seldom used. But when you use it, you may find specific features which may show you know, enhancement around certain areas of the bowel. So early endoscopy is actually advised so that you can have direct visualization of the bowel. And some of the changes may be non-specific, but what you usually will find would be petechial hemorrhages with edematous fragile mucosa with some segmental erythema and scattered erosions. You also would find longitudinal ulcerations, the so-called colon single stripe sign. You may also find sharply defined segmental involvement with cyanosis and cyanosis and pseudopolyps, which suggest transmural ischemia. Just to say that when you scope this patient, avoid over-insufflation, because this may then predispose the patient to complications like perforation. So this is a typical single longitudinal strap sign of ulceration that you'll find in colonic ischemia. This will be a list of differential diagnoses ranging from appendicitis to Crohn's disease and necrotizing enterocolitis. So management of this patient depends on the acuteness and severity of the condition, but most of the cases are usually transient and will then resolve spontaneously. So they don't usually require specific therapy. So, and even they can also be managed as an outpatient with, putting the patient on soft liquid diet and observe the patient. And then you can also put the patient on antibiotics. There's actually no evidence for the use of aminosalicylates or even steroids or immunomodulators for these patients. So basically you just want to, they're simple, uncomplicated, you manage them conservatively, but you need to, you may need to involve the multidisciplinary team involving the surgeons as well as the dietitians earlier on. Usually, like I said, it will resolve over a few days, but when if it progresses or they have more severe cases, then you may need to manage the patient as an inpatient, and sometimes you may need to fast the patient for a few days, fast the patient just to rest the bowel for a couple of days and give them parenteral fluids, and then you may then give them prophylactic anticoagulation and then antibiotics, which I'll talk about later. And then if they have lower GI bleed, you may need to intervene endoscopically. Rarely, some of those patients may require surgery with colectomy. So this would be a list of features that will show that this patient may end up having severe ischemic colitis and may portend risk for failure of conservative management. Things like if the patient is male or if they have pre-existing renal disease or history of atrial fibrillation. And then this will be a list for indications for surgery, if they have persistent abdominal pain without rectal bleeding, if they have pancolitic involvement, especially with isolated right-sided distribution, and then the presence or development of peritoneal signs may be indications for surgery. And then this will be risk factors for postoperative mortality after surgery. And just a word on antibiotics, there's actually little robust evidence for the use of antibiotics, but the general consensus is that antibiotics should be used, and especially those that cover for anaerobic organisms, especially your third generation cephalosporins or your fluoroquinolones. But there's also little data for how long you should use these antibiotics. So, but most people will say use it for about 72 hours and then see afterwards. If there's sepsis, septic involvement, you may need to involve your microbiologist. Other adjuvant management or treatment for this patient, you may need to pass an NG tube or a rectal tube to decompress the abdomen. You may need to do serial imaging or endoscopic evaluation to see how the patient is progressing. You may need to monitor the hemoglobin so that when you need to transfuse them, you will transfuse them, and then monitor the electrolyte imbalances and correct accordingly. So essentially, this is a summary of what you do. Find a patient that you diagnose with colonoscopy for colon ischemia. So what you do is that you give them fluids, antibiotics, NPO, depending on the severity, for about 48 to 72 hours, optimize their cardiac output and avoid triggers and avoid those drugs that have been implicated. And then depending on where the patient goes from there, if there's peritonitis or if there's clinical deterioration, then you may involve the surgeons to cut or to do laparoscopic with bowel resection, and depending on what you find. And then if there's continued diarrhea or not, they still also involve the surgeons. If the patient improves, you may need to repeat your colonoscopy in about 1 to 2 weeks. If they have segmental colitis, or they become symptomatic, or they become systemic, they have systemic compromise, then you then decide on what to do, whether you want to do surgery or not. So usually the cause, like I said, could be chronic or recurrent. Most will resolve spontaneously. And then moving on to diversion colitis. This was first described by Mormon and Dawes in 1974 as non-specific inflammation of a defunction colon. But in 1981, the Glotzer actually coined the word diversion colitis. So basically, what it is, it's a non-specific inflammatory disorder that involves a segment of the colon which was diverted, from the mainstream, and depending on whatever cause, either surgery for whatever reason. So it's actually the true prevalence is unknown, but most people will say that 91% of patients who have pre-existing inflammatory disease and then after surgery we have some form of diversion colitis, and then less patients who have other causes of diseases or indications for surgery will have diversion colitis. The pathophysiology basically is that after you've diverted the colon, either by forming a loop or a colostomy, so that segment of the bowel results in the deficiency of short-chain fatty acids and other luminal nutrients in the colonocytes in the diverted part of the colon. And these short-chain fatty acids are usually the acetate, the propionate, and the N-butyrate. And they are basically derived from anaerobic bacterial metabolism, fermenting the unabsorbed dietary carbohydrates in the colon. And it's also said that the distal colon is more dependent on this short-chain fatty acid for its metabolic needs. So when you now divert, part of the colon from the mainstream, you don't find, the constant flow of this constant flow of short-chain fatty acids, then this would then lead to inflammatory changes, and then would then cause colitis. So usually the presentation is less than 50% of the patient will present with diversion colitis confirmed on histology. We have symptoms, less than 50%, but so most of the patients are asymptomatic. But the typical symptoms are those of tenesmus, urgency, bloody or mucosal discharge, pyerectum, and abdominal pain and pelvic pain. Usually most of the symptoms are mild. In the rare cases, you may have bleeding, and that requires blood transfusion. So diagnosis is combining the clinical picture and endoscopic and histologic findings. It's usually straightforward if you have a patient who didn't have inflammatory bowel disease. But the problem is if you have a patient who had inflammatory bowel disease and had surgery with colostomy and then you have that, and then it may be difficult to determine if what you're having in the diverted colon is a recurrence of inflammatory bowel disease or actually just a pure case of diversion colitis. So what you need to do is combining the history, but you need to take your stool for C. diff, overall parasites, and or exclude infectious etiologies, and then also look for other possible causes of colitis. So when you then go and scope the patient, and the endoscopic findings are usually non-specific, But when you find them, you find erythema, friability, edema, and granularity. You may find ulcers, and you also find a lot of mucosal mucus involvement in the diverted colon. This is typically what you find in the diverted colon, ranging from diffuse inflammation, friability, nodularity, with some outlet stricture and copious exudates in the lumen. The histologic findings usually you find cryptic branching with atrophic cryptic distortion with mucin depletion. You may also find regenerative hyperplasia with some Paneth cells. And but what is the most striking feature is that of lymphoid follicular hyperplasia, which you'll find in this slide. The differential diagnosis, like I said, it's very difficult to determine if what you find in a diverted colon is actually infectious or even high BD, or maybe drug-induced colitis or radiation colitis, or some form of ischemic colitis. So, but this basically would differentiate this other different form of colitis. So how do you manage this patient? So for patients who are symptomatic, the management basically is medical. So what you do is you give them short-chain fatty acid enemas. This has been shown to improve symptoms and to improve the inflammatory changes in the colon. But the short-chain fatty acid enemas are usually not readily available, and even if they are, they're expensive, and they're only compounded by certain pharmacies. So what people have resorted to doing is to use the mixture of coconut oil enemas, and then mixing them with some short-chain fatty acid. So the usual protocol would be to irrigate the diverted colon with this enemas for about 4 to 6 weeks, and this combination usually will consist of sodium acetate, sodium propionate, and even sodium butyrate in certain proportions, in definite proportion, and then you may have sodium chloride as well to improve the osmolality of the composition. And then you also want to adjust the pH of the constitution to about 7 by adding sodium hydroxide. So you give this patient this enemas, and then once improvement occurs, then you can use this constitution several times over time. Usually this has been shown to cause resolution of diversion colitis based on histologic and endoscopic examination later on. But if this doesn't work, you may then end up using aminosalicylates. Sometimes you may use steroids, enemas, and sometimes high concentration dextrose, and even transplantation of fecal biomatter as being used. So this is just a simple case of a patient who had diversion colitis before treatment, and then when they had the short-chain fatty acid enema, you can see clear improvement in the endoscopic finding. But usually this patient sometimes may end up having surgery, with reanastomosis has been shown to restore luminal flow and improve the colitis. So basically, when you reanastomose, then you improve the flow, and then you expose the diverted colon to the short-chain fatty acid, to the bacteria, as well as the nutrients, and be able to metabolize carbohydrates, and this will essentially improve the symptoms. And this has been shown to be the treatment of choice. And then the type of surgery, and then if the patient doesn't improve, you may end up needing to do surgery. Things like your protectomy, your sigmoidopotectomy may be necessarily used. It's been shown that you do not need to survey these patients for colorectal cancer, because there's really low risk for that. Thank you.
Thank you, Joseph, for covering this very large topic so well. And considering the fact that you have recently welcomed a baby boy into this world, congratulations, that you did very well. Sure, it's 7:15. Yes, so I just want to find out if there are any burning questions that anybody has. Nasif, maybe just unmute yourself. Just, oh, Nasif says, thank you for the comprehensive presentation. Yeah, so I mean, with maybe just the last one that you mentioned, divergent colitis, it's like you're damned if you do, you're damned if you don't, isn't it? Because for instance, for some types of inflammatory bowel disease, you divert them, then the disease down below gets better. But then you then also putting them at risk of divergent colitis. Okay, Prof. Setsedi said, well done. Ooh. Can you hear me? I've just been low chat.
I can still hear you now. And Lawrence has his hand up.
Okay, Lawrence.
Good evening, colleagues. Thank you, Dr. Adebiyi, for elaborate presentation. I just wanted to ask, in terms of microscopic colitis, is there any risk for malignancy? And then if we can comment on, in terms of melanosis coli and microscopic colitis. Thank you.
Thanks, Dr. So the data is quite limited when you talk about the risk between the risk for cancer in patients with microscopic colitis, but from most of the data, it shows that the risk is not that significant. So hence, there's really no need to do cancer surveillance for this patient. I didn't see much information in terms of the relationship between melanosis coli and microscopic colitis. So I wouldn't be able to say much about that.
Lawrence, were you asking if there's like an association between the two?
Oh, no, I was just asking, I don't know. I'm asking because I don't know, because I was seeing that some patients who have chronic laxative use, sometimes when you biopsy them, could it be misleading whether you're dealing with microscopic colitis rather than just chronic laxative use? I'm not sure, that's why I'm asking.
So just like NSAIDs, for example. So you find that NSAIDs have been shown to trigger symptoms of microscopic colitis, but on the other hand, we know that NSAIDs can also cause colitis themselves with chronic diarrhea as well. So it's a difficult association, but when you do find patients with microscopic colitis, you have to find the history of NSAIDs, and if they're using NSAIDs, you have to tell them to stop NSAIDs, because most oftentimes the diarrhea will stop. Whether the NSAIDs is causing the diarrhea or the relationship is a causality relationship, it remains largely unknown.
Thank you very much.
Okay, any more questions? Okay, yeah, I think I mean, in view of the time, this just leaves me to thank Joseph for your thorough presentation. Thank you to ECHO, University of New Mexico, and the ECHO India team for their support. A feedback form was posted in the chat. If you can just please complete that, because that helps the organizers to see how important this meeting is. And recordings for this will be available on the Gastro Foundation website. And yeah, thank you to the Gastro Foundation for organizing this meeting. Thank you.
Thank you.
Bye.